Hello, welcome to this month's expert panel discussion brought to you from Inspire Respiratory Critical Care. We put together these panel discussions. We have a podcast. We have all sorts of things. Whenever we video something, record something, we put it on YouTube. Our podcasts are on Apple Podcasts, Spotify, and YouTube. And today we're going to try to pick up where we left off. Our last panel discussion, we talked about PEEP and how to choose PEEP. And we, as usual, ran out of time and had lots more to say. And so we're going to pick up sort of where we left off last time. We'll do a quick overview of the stuff that we talked about last time, and then we'll pick up. As always, you can post comments. Madison's in the background as a participant, and she is going to try to corral questions that are put in the comment section. And there we are. We, as you know, if you've ever attended one of these panel discussions, we're very informal and laid back, and which is one reason why we run out of time. But it works for us, and I hope that it works for you also. So if you look in the chat section, Madison put a welcome message in there. Again, if I forget to say it at the very end, you can always reach out to us if you go to our website. We're a nonprofit organization. Everything we do is volunteer. And if you go to our website at www.inspire-rt.com, you can find links to all of our resources, to all of our recordings, to all of us that are either on the board of directors of Inspire or a volunteer. So Tom will bring up the slides. I guess I could.
I tried to, and I think you might have clicked remove right away.
All right. So here's our first slide, and we will go to what is PEEP? Everybody on here is most likely a clinician that is familiar with what PEEP is, positive and expiratory pressure. I always wanted to have an accent and be able to say expiratory, respiratory therapist, positive and expiratory pressure, and maintains functional residual capacity, et cetera, and optimizes the gas exchange. That is sort of it. So what did we talk about last time? Let me add Danielle to the stage.
Oh, I just did. It's okay.
Okay.
If you're talking, I got it.
Okay. So what did we talk about last time, panelists? We talked about PEEP FiO2 table. We talked a little bit about esophageal manometry and how that the data sort of supports individualized patient assessment and titration. My good friend Eric Kreiner talks about dosing the ventilator to the patient, and we talked about a decremental approach to titration of PEEP. Anybody want to jump in there and just give us a quick overview? What do you think about the PEEP FiO2 tables? Eric or Thomas or anybody?
I mean, the PEEP FiO2, we just discussed it. It's probably the most commonly used sort of default method for setting PEEP, just based on the fact that it's used in so many clinical trials and was officially the PEEP titration method for the ARSNet trial. And we probably also pointed out that every other individualized method has been compared against the PEEP FiO2 table, and we still have limited data suggesting a superior method of individualizing. But this sometimes comes down to the limitations of randomized trials, where both groups will get patients included in the trial that benefit or do fine with either strategy, and those that would not benefit from either strategy. And then it kind of becomes a wash because we're not truly stratifying patients based on, for example, things like elastance or compliance, stuff like that. We're just randomly assigning patients to two groups. So all we're learning with all the large PEEP trials of the past is that compared to a PEEP FiO2 table, if you were randomly to just do this and close your eyes and pick a patient in the ICU, you probably wouldn't see a significant benefit if you randomly selected these patients and just chose a random strategies. Anyone want to add to the PEEP FiO2 comment?
Sure. I mean, like it gets you started, right?
For sure.
It gets you started, gets you stabilized, gets you to a point where you could probably start talking about and considering, individualizing it. I mean, I think it's an interesting dichotomy for me always, because if we're going to titrate PEEP to an oxygenation surrogate out of one side of our mouth, we readily say out of the other side of our mouth that PEEP is used to prevent ventilator-induced lung injury in the form of Adalecc trauma. And we hope that those two things line up, like those two surrogates are kind of on a common pathway, right? And so I think if you get yourself started, and it's not working for you, you need to have kind of the wherewithal to ask the questions and probably, go off protocol, know when to get to the point where, a protocolized medicine approach isn't working for that patient in front of me in that bed. And we need to seek individualization at that point, right? And
Yeah, and
so,
Madison's pointing out that she would argue that's not an individualized method of
yeah,
setting PEEP. Having said that, the argument could be said that, it's a form of individualizing against FiO2,
okay.
right? So technically, if you require more FiO2, then it's suggesting a higher PEEP setting. It's not
Yeah,
individualized for the patient based on their mechanics or what might be tolerable by them. It's simply individualized based on their oxygen requirements, which is not oxygenation is not a very good surrogate for what we should do with the ventilator, as learned
yeah,
by ARDSNet 6 mils versus
yeah,
12 mils per kilo, where the 12 mils group had better gas exchange. And having said that, I do believe on our last Inspire, we discussed how with the lung safe study that people generally aren't even following the PEEP FiO2 table. The average PEEP on patients up to 70% FiO2 is less than 10. And even the low PEEP FiO2 table suggests going higher than 10 when you're on 70% FiO2. Clearly, although many people suggest that perhaps they may use it even as a starting point, they're not actually using it to
yeah.
what it says. People just start getting concerned when they see either higher plateau pressures or whatnot, but definitely not following the typical table in most situations.
Yeah, and anybody can do it, right? You like you said, it gets you started. Anybody can do. You don't have to have a fancy machine or
Yeah.
any kind of unusual apparatus to utilize it. So a good place to start. Esophageal manometry. We some of us use esophageal manometry to evaluate transpulmonary pressure and the effect of extrinsic pressure that's outside the chest, and what kind of influence that might have on the pressures inside the chest. I have used this quite often, and it sort of gives you an idea of what the end-expiratory transpulmonary pressure is and how to set your PEEP. There are people here that are much more uh, experienced with it than I am. Or you have anything that you want to add to what we talked about in our first episode?
No, I did watch it even though I didn't participate. No, I mean, we've been, using it with select patients since the mid-90s. We used the old Bicor machine when we were using the esophageal balloon back then. And, all it's done is show us that we're not really a PEEP-ophobic institution. So we're not really too frightened to turn the PEEP up to 15 or 18 or 20, especially with people that have higher BMI, and we're still able to keep their driving pressure and plateau pressures within range.
I'd argue that's one of the benefits of starting to use esophageal pressure, particularly in obese patients, is that you realize how underpeeped you were with these patients. In particular, that group of patients, that subgroup of patients, really, I would say more times than not, responds extremely well to titrating PEEP according to the estimated pleural pressure by esophageal balloon. And yeah, you have these magic moments. Like if you were to start using esophageal pressure in a hospital for the first time, I highly suggest choosing an obese patient as your first aha moment to demonstrate the benefits, because you're going to see, you're going to see some significant responses. If you put it into, a 85-year-old tiny little frail lady in your ICU and titrate PEEP according to it, you might not get the same reaction or the same response from staff. They're going to say, oh, yeah, okay, that's cool. Looks like a lot of work for something that didn't tell us a whole lot of information. But when you have a morbidly obese patient and you're scared to go above a PEEP of 12 or 14, this is where you're going to have a huge impact. And Danielle, you had sort of summarized very quickly in the last, we try to do everything quickly, but we tend to take forever when we converse about it. But you summarized it last time. Do you have anything more to add regarding that? I mean, I think you also are quite comfortable with suggesting this therapy with obese patients as being like the absolute targeted patient population.
Yeah, so for us here in North Carolina, that is what we tend to go towards is geometry. I hope everybody can hear me okay. I was able to test audio on my laptop, but essentially we're just trying to utilize it to find their optimal PEEP. If possible, we are not, like Troy said, we're not scared of PEEP here. We've been using esophageal manometry. It's probably 2010, 2008, 2010, right when they started it here. Um, Manager now was actually in like the first commercialized photos support for Hamilton Medical back in the day. So we were utilizing it back then. We had a more morbidly obese population, but we have patients that were like 600, 700 pounds. So we utilize it to hopefully get them off the ventilator as well. Sometimes we'll extubate to BiPAP. Sometimes we actually have these patients already trached and they were a slow wean, unfortunately for us. So we use it. Hopefully, we don't have a lot. We can prevent alveolar collapse with those patients. It's pretty much it. We kind of touched on it last time. That's the main patient population we use it in. We utilize it for ventilator asynchrony as well, just to kind of do some teaching with some of our residents and some of our fellows and some of our attendants here at our medical center. But besides that, the morbidly obese population is like the number one population we use it in.
Yeah, we should point out to the listeners that using esophageal pressure for monitoring asynchrony or effort actually is the gold standard. So any study that's done that, for example, is testing an algorithm that automatically looks at waveforms and determines asynchronies, for example. The gold standard that it's compared to are experts looking at esophageal pressure waveforms or EDI, but the gold standard really has become esophageal pressure when it comes to monitoring effort and patient ventilator interaction. And then anything that is testing another method of determining those things, they're really comparing it against esophageal pressure tracings during spontaneous breathing. And now decremental PEEP titration.
Hold on.
Sorry,
Let me
you want to
let
add
me
to
jump
that,
in.
Eric? Go ahead.
Yeah. I think, the conversation that we've been having a lot lately, and I think we just kind of got we got a hold of a handful of patients that weren't recruitable, essentially, right? Yet they were morbidly obese. So they were kind of in this kind of special cohort where we really started kind of asking.
How are you determining recruitment potential, Eric? Just for the
Sure.
listeners.
RI and EIT.
Okay,
essentially.
so I'm just going to intervene for a quick second.
Sure.
So EIT, fantastic. RI ratio, unfortunately, and I'll throw this out there, does not work successfully with obese patients. In the original study, they only had one obese patient in the whole cohort. It was only a study of like just over 40 patients, and there was one obese patient. And I remember having this discussion with the author when I measured it on a number of obese patients, and it kept saying that they weren't recruitable. And I'm like, this is crazy. But then we put EIT on, and we're like, okay, this person definitely benefits from PEEP, and of course their esophageal pressures were also elevated. So, and then they responded fantastic to higher PEEP. So, when I had let the author know, he said it didn't really agree with me at first, but then it was actually a year or two later. He sent me an email and he says you were right, and he just said their underlying FRC and the pleural pressure is elevated. It's such a complex scenario that it actually does impact the accuracy of the RI ratio. So I just want to throw it out there. And that's why I wanted I was hoping you'd say RI ratio so I could point that out. But if you have esophageal pressure, EIT, they're complementary. So yeah, if you're using EIT and you don't find it recruitable, that's great.
Yeah. I mean, so when prior to EIT, we were doing it academically. We just kind of gathered that data, didn't really utilize it to make that decision whether to go to that end expiratory transpulmonary pressure of 0. We just went and followed the driving pressure along the way to make sure that we were on the right path. But I think with our institution of EIT, and we got more nuanced with it, with seeing that in these burn patients, in a morbidly obese patient with an intrapulmonary process, it's really made us kind of think twice about throwing the balloon in, where we were just super enthusiastic. Yeah, let's go to 26. And we would ride it all the way up and just be aggressive with it. Whereas now I think we're much more nuanced is the word, and discerning about like, okay, we have the number, we have a target, we know where we need to get to. Let's make sure that it's appropriate to go up there, right? And so we ask that question a lot more now that we have the EIT with us, and we can actually quantify. We're over to send it much quicker or much sooner at a much lower peak than a 0. So we've gotten ourselves into like a lot of debates about that. But yeah, so we use it a ton.
Keith, did you pop that question up? I wasn't sure because I was going Okay, because I was typing a response and then it popped up. I'm like, did I do that?
Oh.
So in terms of determining recruitability in an obese patient, if I didn't have any tools whatsoever, I would probably assume recruitment potential with most obese patients. I think what Eric was describing is like probably the minority, which is why we should never assume. But if you had to assume, it's a good population to assume it with. Having said that, one technique I would do, which doesn't determine recruitment potential, but it does determine airway closure and the minimum requirement for PEEP. So that would be one thing to do, is to assess airway opening pressure. You can do this either with a pressure time curve using volume assist control in a passive patient, or a PV tool or a pressure volume curve. Again, in a passive patient with slow flow inflation, looking for that inflection point. This will tell you the minimum level, and it likely describes the range of airway opening pressures you may see in that patient. The more abrupt the inflection, the more accurate it is. The more progressive it is, there may be differences throughout regions of the lung for airway closure, but it'll give you at least a starting point. And then other than that, I really would look at their response to incremental PEEP changes and driving pressure, because anyone who's used esophageal pressure in this group, when you get the patients on this optimal PEEP based on esophageal pressure, you very regularly in this patient population see a significant reduction in driving pressure. Again, particularly this morbidly obese populations. Again, in the absence of tools, you can learn to do or to check for airway opening pressure, or use your PV tools or PV curves, whatever you have available on your ventilator. And then when you increase PEEP levels to this level that might seem uncomfortable for you, pay attention to driving pressure and see the impact it's having. If the driving pressure is increasing significantly and above 15, you may be going in the wrong direction. So I would start there.
What about patients that aren't passive?
That aren't passive, I would look at work of breathing, because there's really nothing else you can do that would be accurate aside from looking at work of breathing. Yeah, you can titrate up, look at P0.1, look at the patient. You could do some POC measurements, but yeah, once they're breathing spontaneously, it's kind of again, in terms of increasing PEEP to lower respiratory drive, it's only successful in patients who are actually recruitable, like whose compliance improves with increasing PEEP. So you'll see it if if that's what it's doing, you'll see them reduce their drive. If they don't, you may not be recruiting much if they don't sort of lower their respiratory drive or effort.
Yeah, because people who are alactatic typically should have if they're neurologically intact, should have a drive, right?
Yeah,
Yeah.
yeah. Initially, like there were some early studies by Takeshi Yoshida looking at PEEP as a modulator of respiratory effort. So, like higher PEEP, sort of lowering the impact or the possibility of PCILI by lowering effort when PEEP is increased. But when it's been studied in human patients and again, more general hypoxemic respiratory failure patients, they found that the benefits of PEEP towards respiratory drive and effort really only occur when respiratory system mechanics improve, right? So same idea with driving pressure. This would be an improvement of mechanics if it's significantly decreased, but that's how you know if it's benefiting the patient. Yeah. Just for some objective numbers, you can always look at the patient and say, well, they look much more comfortable on a PEEP of 15 than they do on a PEEP of 8. But of course, we have some objective measurements we could take, like P0.1 or POC, to see if the effort's actually reduced with that.
And in terms of using P01 or POC, which one would be a better reflection?
Personally, I don't feel that those tools give enough information on their own. I think that combined, they have a much generalized assessment of what's going on, for lack of a better word. So P0.1, for example, if the patient has some delayed triggering and some auto PEEP, the P0.1 may be lower than expected, because by the time they trigger the ventilator, there's not much left in terms of their drop in pressure at the trigger point. So when you look at that versus a POC, the POC will show you the full effort because it's a complete occlusion, so you can see the impact that their effort is having. So usually I would say use them both if possible. Every ventilator has P0.1. POC requires you to sort of learn the technique, which is not complicated, but it's very easy to learn how to do it. It's just an expiratory pause. If your ventilator doesn't allow you to do it, you got to use a NIF. And I think we've discussed this on previous episodes that people can wander back and check out.
So Danielle had a statement / question.
Well, Eric kind of answered it when he was going through his story a little bit, because the first thing I thought of when he said we have this subset of patients, I was like, oh, it must be somebody with an intrapulmonary process. And I think I touched on it a little bit, like very quickly last time. That just because I might find that we're using a balloon, someone's morbidly obese, they got transferred here from a smaller facility, and we find that their optimal PEEP is 22. They're morbidly obese. That doesn't necessarily mean that I'm going to put them on that PEEP of 22. So I find that they don't do well with that PEEP of 22. They might do better at the moment, just with like a PEEP 18 or a PEEP 16. And that's just because they have a different process. When we're putting in an esophageal balloon and we're looking at all these lung mechanics with the ventilator, it's not like EIT. It's not telling us every single part of the different areas of the lung, right? It's treating everything as one big unit, and that's also I love a PV tool, but at the same time, it does the same thing. It's treating every single part of the lung as the same process. So that's kind of a nuance with it, and we do teach that at our facility, just because I don't want someone to cause harm, thinking, oh no, it says that this patient needs a PEEP of 22, but they might not do so well.
Now, I'm going to tell a quick story, and I think I'm assuming both you and Eric would agree, despite you both having this experience where obviously an intrapulmonary process could be not as opening to your therapy of PEEP based on pleural pressure or transpulmonary pressure. But we had a patient who was admitted, and again, the issue is knowing the diagnosis versus the perceived diagnosis, right? So this is very important because we had a patient admitted to our ICU with quote unquote intrapulmonary sepsis. That was based on their presentation, the fact that they were acting sepsis, and their x-ray looked like pneumonia, but a very atelectatic lung will also look like pneumonia, right? So this patient responded very well to PEEP to the point where 24 hours later, their x-ray was completely clear, and they realized that this patient does not have intrapulmonary sepsis, and it forced them to look for another source of sepsis. I agree. You will see those situations if they have a true intrapulmonary, like a rip-roaring pneumonia with consolidation. That's not stuff that's going to open easily. Or a huge pleural effusion, right? You can't recruit a pleural effusion. So these things are very, definitely can impact that, but always be sure that you're at the point of diagnosis, read the notes or hear what they're saying. When they say admitted with, intrapulmonary sepsis, it's like, how did they determine that? Right? Did they actually do any testing? Because this lady, it was just a running theory. She came from Emerge and they had an x-ray and all this stuff, looked horrible. And then she got intubated and then she came up and that was just the running diagnosis, but it wasn't actually confirmed. And then we completely threw them off their game when we increased the PEEP and showed a perfectly clear x-ray by the next day.
Yeah, I'm thinking more of like we're a level 1 trauma center. So let's say I get this morbidly obese patient. Maybe they were riding on a motorcycle and they recently just ate and they aspirated. So it's like or maybe they went into a ditch and now they've aspirated all of this
Mhm.
gunk stuff out here in the swamps. Things of that nature. That's
Yeah.
kind of really the picture like we try to paint for all of our fellows, because we don't have just pulm crit care. We have crit care, we have ID, EM, crit care, nephro. Then we also have our surgery trauma fellows attend the class too. So we want to make it like a real live patient for them if possible. But we see that here for sure.
I'm going to think of you the next time I ride my motorcycle by a swamp. And be like, don't want to end up in there.
Plenty of wetlands, yeah, on the coast. So.
All
Yeah,
right.
you can
let's-
drive
let's
by the
end-
swamp, just stay out of it.
Yeah, exactly. Just don't veer off into the swamp. Let's move. I'm gonna try to keep control of this and move forward. Decremental PEEP titration. I think we had touched on this. We had mentioned EIT, and I think we're going to talk a little bit more about EIT today. And I think so. It's a fitting end to that. But in terms of decremental PEEP titration, who wants to explain this process? Troy, why don't we get you going in there? I see you reaching for your mouse to unmute because I know that you utilize this both with EIT, but maybe you also utilize this prior to the ART trial as a method for setting PEEP. I'm sure many of us did on a regular basis, but maybe started questioning some of our techniques after the ART trial. But go ahead, Troy.
When we first got our ventilator guidelines approved at our hospital, if a patient was on 50% or greater, we automatically did 40 for 40 every 4 hours and reassessed it. That quickly went away. We realized that was way before the ART trial. The ART trial was painful. The way they did the decremental PEEP trial, it just seemed like it took so long and it was so time consuming that they had some adverse events for sure. Death, I think, also. But we don't routinely do recruitment maneuvers. That does not mean we don't do them at all. Now, as far as setting PEEP with a decremental titration, we do it all the time with EIT. We also have done it in other situations prior to EIT. Basically, what you're looking for is excuse me, is the best lung compliance at a certain level of PEEP. So you're keeping track of tidal volumes at different levels of PEEP. You basically want a passive patient. You don't want effort to be involved. And you go through a series of PEEP levels and decrease them by 2 or 3 centimeters every certain amount of time. keeping track of what's happening at each level. Then there are some ventilators that will keep track for you. You don't have to put much thought into it. You just make the decreases in the PEEP and go back and look at what you did later. You can do it in your head. You can do it on a piece of paper. There's multiple ways that you could potentially do it. But basically, when you go back and look at the information, you're trying to find that sweet spot where the patient's ventilating, getting the most volume with the least amount of pressure at that level of PEEP. Anybody can pipe in and be a little bit more clear than I was, but that's basically how we do it here.
Yeah, essentially the best compliance method was sort of the original method for using it, or sometimes best compliance plus 2, like you'd increase PEEP by 2 after best compliance. There were variations of the protocol out there. This quickly, I wouldn't say fell out of favor, but a lot of people started questioning the best compliance choice for PEEP when two things happened. One, when the ART trial was published, because this method, again, people were blaming the aggressive recruitment strategy prior to doing the decremental PEEP trial, but definitely there's a lack of evidence. There was a study that was stopped early that the late Bob Kazmarek was involved with. It was stopped for futility. So we really didn't have much data suggesting that this was the best way to do it. And then, so the second reason why people are starting to not doubt decremental PEEP titration, but to question the use of compliance is when you start using EIT. And for those on the call who are using EIT, particularly with the Timpel device, where you have the reading, it actually calculates respiratory system compliance at the same time that it's assessing regional compliance. You will find in many patients that the optimal PEEP that compromises over distension and collapse doesn't always line up perfectly with the best compliance. So some patients, as collapse gets worse, compliance continues to increase. So there's clearly tidal recruitment, but the compliance gets a little bit deceiving in terms of like, should you set PEEP at best compliance or not? So yeah, anyone else want to So Troy, I'll ask you that question because I know that you guys started using EIT at least a year ago or more now, and you continued to use decremental. Were you finding this discrepancy in some patients where if you had looked at the compliance curve, you may have missed the optimal compromise of PEEP?
On a regular basis.
Right.
Yeah.
So I'm not just making it up.
Not at
You're
all.
being validated. And Eric's shaking his head too. So you obviously have seen that. And Danielle, you have EIT at your institution? No, not yet. Okay.
No, I'm waiting for the Hamilton collaboration.
Right.
That's probably when we'll get it.
Yeah, Madison and her team on this
Yeah,
certain
they just got one.
trauma service just started to use it this week, and she's already used it on a couple of patients. I remember back when I trained at my first place that I worked after I trained, we used to do sort of a, I mean, this was, there was no such thing as EIT. We did use the bicore device just to measure work of breathing, though, not to make any kind of ventilator management decision necessarily. But we used to actually put, and this was back when pressure control was not really, it was thought of as a rescue mode of ventilation. And to be honest with you, I use more pressure control now than I do anything else. But way back then, we used to put a patient in pressure control. We used to bolus them with a neuromuscular blockade. We used to go up on their PEEP by 2 centimeters of water every few minutes while they were paralyzed, keeping the delta the same for each measurement. And then when we started to get more tidal volume with the same delta, then we thought we recruited. We didn't. So it was a very archaic sort of incremental increase in PEEP, and then we would sort of stop right there. Anybody ever do that in their practice?
Absolutely.
Yeah.
Yeah, I mean, I think we do it sometimes when we're not even trying to. Like sometimes you just increase PEEP without getting all the tools, and you're like, and then of course, if you're just reassessing, like if you notice something like tidal volume increasing, particularly if you're using pressure control, you automatically make that assumption, like I must have opened some stuff up because now I'm getting more volume. So I think we've probably all seen it, even if we're not even trying to do it purposefully. I have used EIT in that way to assess recruitment potential. So what I typically will do is whatever clinical PEEP they're on, I assess them prior to doing a decremental PEEP trial. And how I do that is I look at them on the current PEEP setting. Let's say it's 12. I'll increase by 4 for 1 minute and then increase by 4 again for 1 minute, assuming that they tolerate it. And then I will put them back on clinical PEEP and assess those PEEP changes by looking at the trends and looking at compliance changes. Now, this is specifically on the Palma Vista 500, which isn't available in the US. I use that here in Canada. But I would assess the regional compliance changes with each of those incremental PEEP steps. The reason why I go back to clinical is because If it's not beneficial, I don't want to keep them on this higher PEEP level. I'll put them back while I'm looking at the data, and then I'll assess. And in some patients, you see that there's just as much compliance improvement as there is compliance loss. So you're still on sort of a linear relationship between overdistending and collapse. But in some patients, you'll see more compliance improvements in the dorsal regions, then you will see loss. And this is clearly someone who has significant recruitment potential. And then some patients is the opposite, where you just see the compliance loss as you increase PEEP with very minimal compliance gains. So this would just tell you that by going up by 8 centimeters of water of PEEP, there's no benefit, or there's significant benefit, or it's a balance. And then, so in the patients where it's a balance or there's recruitment, those are patients I would go ahead and do a decremental PEEP trial from a higher level of PEEP coming down. And the ones that have no benefit in that little PEEP trial, that incremental PEEP trial I do, those are patients that I would immediately suggest proning, simply because I think we're wasting our time with trying to find an optimal PEEP, and we know proning works. My reason all the time of using is like, I think proning is excellent. It has evidence to back it, but it's a lot of work if all you need to do is give an appropriate level of PEEP that other people or other clinicians around you are just scared to use. So as soon as you have a device that can show you the impact of PEEP, you really can advocate for your patient a little better when you have the proof beside you at the bedside.
Yeah. Yep.
There
So
we go.
what's on our list? EIT. So
Yeah,
so
there you
you
go.
guys have touched on it already.
I think we basically just described it.
Yeah, you did. So if you have EIT, then clearly it's an actual image, a better picture of how increasing index-tory pressure affects regional changes, even pendulum, right? And regional changes in inflation and recruitment.
Yeah, there's so much information. I mean, if we want to keep it specifically to PEEP, then obviously the decremental PEEP trial, how EIT determines an optimal PEEP level is by doing a decremental PEEP trial. And then what happens at the highest level of PEEP you choose and the lowest level of PEEP you choose, those become the references for compliance changes in between that titration. So, for example, a PEEP of 5 would have 0 overdistension. Even if you had a patient who could still be overdistended at a PEEP of 5, it would show 0 hyperinflation. If you started at a PEEP of 20, at a PEEP of 20, it would say that they had 0 collapse. Even if they had collapse in the lungs, the reference point becomes 0. And then as you go from 20 down to 5, it shows you the delta, the change in compliance throughout the regions of the lung. And so you'll have areas where compliance is improving as you decrease PEEP, and those are areas that are marked as overdistension at the higher PEEP. And then you have some areas where compliance starts to decrease as you lower PEEP, and this becomes areas that are marked as changes that represent collapse. And then what it does is it maps out these overdistension assumptions and these collapse assumptions, and you get a crossing point where you are basically choosing to compromise between overdistension and collapse. That's the most common method for setting PEEP with EIT without having a visual graph on the slide. I can bring one up if we need it, but I think we've also done this in other talks as well. So just keep with the discussion. Anyone want to add anything to that, or? Because we could get into other stuff, but I think the other methods for EIT, like Pendelupt and stuff, that comes into spontaneously breathing patients and not necessarily PEEP. Although PEEP can impact drive, as we already discussed, EIT is a way of seeing if it benefits, but we can save that for another discussion.
Danielle, you mentioned something about new technology. Do you want to elaborate on that? Did you say something about Hamilton? Because the only device I know of right now that's available is the Tempel.
They are partnering with them and with Tempel. So at APRV last year, they announced a collaboration with both companies. So I've been told that would hopefully happen this year. They shared it online, I believe, too, as well. But that's probably how we're going to end up obtaining EIT at my facility, just because of contracts and vendors. That would be a new vendor, new contract. And if Hamilton Medical is already listed as a contract, that goes into all the managerial types of stuff I try to stay out of. Possible. I really do want that technology because I think it would be very beneficial for some of our patients here. And I think it would be very interesting just to see, because we ventilate so differently, and depending on what area of the hospital you're in, I think it would be nice to have. The one thing I do have a question on, I guess, with EIT and then with the PEEP is, has anyone looked at different positions of the patients? Different positions. I know they touched on some of that last year, but I didn't know if that is a routine in the institutions that are utilizing that technology.
So most of the studies looking at positioning are just trying to see the impact that position has on regional ventilation. Because with proning, even without EIT, when the ProSeva study came out, there's all these papers talking about the physiology of proning and how you increase ventilation to the dorsal lung regions, et cetera. So EIT was more confirmatory with a lot of those studies. And then when it comes down to like the lateral positioning, again, this would depend on the patient's underlying condition. But what the positioning data with EIT is showing, at least in the animal model, is that, for example, in a prone position, you homogenize the regions, the best compliance per region. What that means is generally your respiratory system compliance overall at the ventilator reflects a combination of overdistension and collapse, right? We know it's just telling us the compliance of the whole respiratory system, but we don't know how that is distributed throughout regions of the lungs. And when in the supine position, the best compliance for the ventral regions or the open lung, the baby lung, is different than the best compliance for the dorsal lung region and is also different from the respiratory system. So the respiratory system reflects one region more closely in supine. When you pronate, you actually get a more homogeneous distribution of the optimal compliance per region. So in fact, if you were to do a decremental PEEP trial, it's probably more accurate description of what the patient needs in the prone position than it is even in the supine position. So yeah,
Maybe
there's
that needs to
definitely
be a study then, Tom.
what's that?
Maybe that can be a next study then.
There,
Just to reiterate again, because I don't know about you all, I guess to get into proning, but even with COVID for a while, we were proning more regularly. Now it's like everyone doesn't want to do it anymore.
yeah. So that's I mean, when you I'm going to say when I'm just going to assume you're going to get EIT at some point. I'd say when you get EIT, I would get in the habit of again assessing the patient's recruitment potential with EIT. So we published the Recruit study 2 years ago now, or maybe it was early 2025. And just showing that patients have different, there's like mild recruiters, there's medium recruiters and high or low, medium, and high recruiters. So with EIT, you can demonstrate this. You can say, okay, this is a patient with high recruitment potential. So in patients with high recruitment potential, you want to first try to optimize their PEEP. At any point, you optimize someone's PEEP if they don't improve. Proning, we know, works, right? So but in those patients, if I did a decremental PEEP trial or I did my little PEEP test I mentioned earlier with EIT, if I found the patient does not have a significant potential for recruitment, I'm not going to waste time trying to find an optimal PEEP level for someone who clearly we should just prone. But this is where EIT can then show you the potential benefits of proning. So this exact example, I have a case example from when I worked in Toronto. It's a patient who I did that little incremental PEEP trial, non-responsive to PEEP. The improvement in compliance was 4%. The loss in compliance was something like over 30%. So clearly not a responder to PEEP. We instantly proned and the dorsal lung regions just completely opened up the minute it's like PEEP could not recruit and open this lung in the supine position. The minute we put this patient on their belly, it was a completely different story. But we had the EIT to visually show us. So it really got everybody excited because you're like, they don't respond to PEEP. What's the chances they're going to respond to proning? But then you can now visually show, look at the difference, right? So, and not every patient will respond that way, but it was.
It's magical.
Okay, here we go. We got to.
Here we go. All right,
we go.
Pablo, starting stuff up. Let me read this out loud. Can I read it out loud? All right, Pablo, regarding recruitment in optimal settings, do any of you use APRV, TCAV? One can get driving pressure, trend compliance, use T-low to assess recruitability along with the expiratory hold. Just like the other modes, only difference is tedious mode and comfort level, but argument can be even though one might be comfortable with volume control, pressure control modes, it doesn't necessarily mean one is optimal setting the vent unless one has EIT.
I guess I will take a stab at this. I will say that, yes, you're going to have to argue that is the clinical user setting up the vent, are they comfortable with that mode? Because you can be really dangerous if you do not know how to utilize that mode appropriately. And I do utilize TCAV and I use that approach, but I also will not just recommend just somebody just putting it on a patient either. Because you could really harm a patient. And I don't agree with trying to use poor man's APRV either for that. And I hate to say it like that, but I'm very big on please know what you're doing with the ventilator. What are you comfortable with? I'm all for people wanting to learn it and how to use it appropriately. But over time, that is when we're recruiting the lung with APRV. And you will see the driving pressure trend down. And essentially you are recruiting and you will be on CPAP, but you're just recruiting over time. And it's not going to work for every patient. I am a big believer in utilizing the tools I have in my tool belt for patients. And I do utilize TCAV in our MICU, which is kind of shocking to some people, but depending on the patient's condition, it goes back, what is the patient's condition and what what will benefit that patient. Could you argue maybe that patient could have been on a different mode? Possibly, but we utilize it here at our facility and our staff utilize it often. So they are very comfortable with making those changes.
Just to add to what she said, I think using EIT, you're going to have to set T low to try to minimize collapse with APRV. But as she eloquently stated, P high and time are what's doing your really recruiting if you're using APRV. So optimizing those are going to be just as important, if not more important, than getting that T low set to get maybe the results you might be looking for if your patient's a candidate in response.
Eric, I have a question for you. While we wait for the lung to recruit, what do you think's happening to the areas that are already open?
They're overdistending. Yeah.
This is, I think this is the main point I want to make to why we need more clinical data, because we can do a lot of things. I mean, this was the whole problem with the recruit trial. Prior to recruit, this maximum recruitment strategy of using like pressure control of 15 and a PEEP of 25 and going all the way up to 50 or 60 centimeters of water, the preclinical data was actually really impressive. Like Amato had published papers where they were like reversing ARDS in like a significant portion of patients simply by using this aggressive recruitment strategy. And so to say, well, recruitment takes time, so we have to apply the appropriate pressure to recruit them. What is the appropriate pressure that doesn't overdistend the lung for the next 24 hours while we wait for the other area to open up? So we still need good and better prospective studies. Having said that, there apparently is finally a randomized control trial of TCAV that will be, I don't know if they've already started, but it's going to be led by, I believe, Dr. Luigi Comparata out of the UK. So hopefully we will finally get an RCT, because right now the largest RCT we have to date that is the closest to TCAV we have. The people that promote TCAV say it wasn't close enough, but it was the closest, was stopped early for harm in the APRV group, or potential for harm. So they stopped the study. So we do need that data.
I'm always suspicious when somebody tells me something works, right? And my follow-up question is, what do you mean? What do you mean it works? Well, I put this person on, and trust me, the very first thing I ever published was an abstract about APRV 6 months after we got our first draggers where I trained. And so I have used lots of APRV, and we use the TCAV approach. But I'm very suspicious when somebody says it worked, and I say, what do you mean it worked? And, oh, our oxygenation improved, and we were able to come down on our FiO2. Well, we know that doesn't mean anything. We know that improving somebody's gas exchange does not correlate really nicely like we would like for it to
with outcomes,
to survival. So, we just don't know, and like you said, what is it? If I put somebody on a PI of 26 for 5 or 6 seconds, during that 5 or 6 seconds, depending upon time constants and recruitability, and, some stuff's the recruiting, some stuff's over distending, we know that mortality in ARDS is very strongly associated with an exaggerated inflammatory response, and probably an exaggerated inflammatory response due to overdistension and increased transpulmonary pressure, right? So, yes, 80% of people or so their gas exchange will get better when you put them on APRV, they'll oxygenate better. But do more people live? That's the question I have. More people, and that's why it's not something that I just my standard approach in somebody who's hypoxemic. It's just, it isn't now, it never has been. And until I see some data that tells me that, hey, mortality is accepted if improved if you put the right person on APRV. We know that the mortality benefit from proning patients is not because they oxygenate better. It's not. It's because you have decreased the opportunity for injury, and that's that just
now, that is my biggest fear. That's my biggest fear. Someone's like, "Well, it works, so we're going to use that instead of proning." And then my first response is like, "What has the strongest evidence?" And the strongest evidence we have is proning. Of course, there are patients who you can't prone for various reasons. So I'm not saying like if you're doing something extremely bad, I'm saying we need data to prove that we're not doing something bad by randomly assigning patients to use APRV. Like there might be a subgroup of patients that do actually benefit, that don't benefit from something else. Some of the case reports that always frustrate me is when someone shares a case report of APRV on Twitter or X or whatever it's called now. And, you look at the pre-settings, when you ask them what PEEP were they on prior to switching over, like they were on a PEEP of 10. And I'm like, "Okay, did you
Yeah.
try higher PEEP?" And they're like, "No, we were uncomfortable going higher than 10. I'm like, "But you're not uncomfortable with a P high. You're not uncomfortable with a P high of 30. I don't make that make sense. I don't, it doesn't make sense to
Oh my
me."
gosh.
So yeah, essentially we need data. But in terms to answer the question about how you measure delta P in a patient on TCAB, you basically use the other driving pressure calculation, which is tidal volume divided by respiratory system compliance. So you take the release volumes and then you divide that by your respiratory system compliance, which should be, most ventilators will display a respiratory system compliance. And because because your P high is elevated for so long, it should be an accurate representation. But there's papers out there by Gary Neiman and colleagues that describe using exhaled volume divided by your respiratory system compliance to determine driving pressure. I've seen patients that were on APRV for 5 days. I came in and I did that measurement, and the driving pressure was 27 centimeters of water. And no one had questioned why the patient was getting worse over 5 days. And no one just thought, they thought we shouldn't change it. And I did a recruitment to inflation ratio on this patient. They weren't obese. And guess what? They were not recruitable. So that 5 days of APRV, I'm sure was not, we were waiting for a lung to recruit that had no recruitment potential. So, we really do need to study this properly. And I love how someone says a 3100 paradigm shift. I was going to ask how many people on the call feel that they saved a life using HFO. Seriously, put up your hands. How many people felt that at some point in their career they saved a life with HFO? If you used HFO on a patient, you saw a patient turn around so drastically and you feel like we saved their life. But I bet you if you went back and audited many of the charts, you'd realize that when you were gone for 6 days between your shifts, that patient died. So we really need to, this is why we need
I could
proper study.
honestly say I've never thought that HFO saved a life. I never saw better ABG, never saw better oxygenation.
Oh, really?
No.
Yeah, I
no.
mean, I've seen
I've definitely seen it, but again, I
high
can't.
frequency is the number one impetus for somebody telling me that something worked. Like that, I've heard more. In my lifetime, I've heard more people say it worked. It worked, and I said, Are they still alive?"
I asked people, did they walk out of the hospital and did they
Yeah.
live?
And most people don't know the answer to that question, right? This is
And
my
they
whole
don't.
point. This is
And
why we
that's,
need to.
and that's why
Yeah.
we are trying
We
to.
are so biased by our shift experience, right? You have a patient for a couple of days, you're like, I optimize them, they're doing great, you leave, but then you come back a week later and you have completely forgotten about that patient. And if you remember to ask, they might say, "Oh, they got shipped to the floors." And you're like, "Yes, that's amazing. I bet you I was the one that saved their life." But what you don't know is a week later they arrested and died. Like there's so
Yeah.
many, like this is why we have follow-up data. This is why we have ICU and hospital mortality.
Yeah, like
Sorry.
our podcast with Farhad from India. We talked a lot about distant outcomes. Like we don't really know until we follow them up. Anyway, let's move on to this thing is about PEEP. So let's move on. We cannot have a PEEP part 3. Combining modalities. Anybody want to approach this?
Well, how many or who has combined? I have combined modalities, but I'm going to ask others. Have you guys combined modalities, and what additional information did it provide you? Nobody else has combined modalities. Okay.
Sure. Well,
Go ahead, please.
That's kind of what I was referring to, and when like my initial comment about the use of transpulmonary pressure, combining it with EIT, right,
Yeah.
and doing the decremental PEEP trial, comparing it to just a plain old straight up expiratory transpulmonary pressure of 0, and understanding that there is a difference in this particular patient at this particular time. And so we often combine them. They'll get a balloon and EIT, provided I can get a belt around them.
Yeah. And you would agree that, again, esophageal pressure, transpulmonary pressure, we understand the concept of like, okay, if the pleural pressure is 12, we should match it with a PEEP of 12. But this relationship assumes recruitment potential.
Yeah.
So this is why these tools can be complementary. Could you just do a decremental PEEP titration without esophageal pressure? Sure. I would say one of the benefits of combining the strategies is one will tell you perhaps how high you need to start your decremental PEEP trial from. Because if you just said, okay, we're going to go 20 to 5 in a patient who weighs 500 pounds, I'd say you're not starting high enough to find the optimal PEEP. You will find a crossing point. Like you will find an optimal PEEP, and it's probably not going to represent what's actually happening. So if you have a patient with a pleural pressure of 20 or 22, you probably want to start that PEEP at least something like 25 or 26. You want to start above the pleural pressure and then titrate PEEP down, rather than just saying, oh, we do all of our decremental PEEP trial with EIT on 20 to 5. Meanwhile, pleural pressure is 22 or 24. So you're completely you're starting at a PEEP level that's not even high enough to match their to equalize transpulmonary pressure.
I think it's safe to say that if you have it available to you, you should always use multiple approaches and sort of come up with because you're going to get the highest fidelity intervention by using multiple different approaches.
Yeah, I mean, without dropping the balloon first, that would we talk like I feel like I'm guessing at my highest up, like trying to figure out where my upper inflection point is, and sort of going up there with the EIT for the decremental PEEP trial. I slip the balloon in. We usually just go +6. That's just a nice round even number. Slip it in. We get a pleural pressure of 20, we go to 26.
To do your decremental.
To do our decremental. Yeah.
That's a good strategy. You'll get at least 6 data points above what you suggest. Again, if you just had one tool, you are assuming that there would be an optimal PEEP of 20, right? So your assumption's there. So you want to get at least, again, if you're dropping every 2 centimeters of water, or if you're dropping 2 centimeters of water, you have at least 3 PEEP steps looking at compliance changes. So that can be very helpful. I'm going to try a new feature that just got added to StreamYard that we're using. That's what we use for this whole thing. We have polls. So for those who are still online, we're going to start this little poll just so that we can play around with this and see what happens. All right. So this should show up on the screen somewhere in the bottom left corner. If you individualize PEEP in your institution, which method is most commonly used? Decremental PEEP, and it can be with or without EIT, esophageal pressure, driving pressure, or other. And I have no idea if anybody's responding this. Good question. Maybe the panelists cannot respond. Can someone in the chat let me know? There we go. It's starting to show up. Looks like. Okay. So type 1, 2, 3, or 4 in the chat. That's how you respond. Okay. I didn't see the subtitles there. Okay. So I'm going to do. Now, if you use all of the above, I don't know that you can vote multiple times, but I would say what's the most commonly used in your institution? I guess we can vote just by typing in the chat then. I'm going to say most common on the last place I worked at.
Oh, this is pretty cool.
Yeah. I mean, we'll utilize this for future sessions. That the only thing I don't like is that if you want to answer anonymously, you can't, which this is not the type of question that it matters. But maybe if I was asking you if you think APRV saves lives, you might want to answer anonymously.
I'm proud.
Until we know, it might. And then listen, I will be the first person. I'll be the first person to admit I was wrong when the data actually shows that I'm wrong. I'm not wrong. I have never said it will cause harm. I said we need to be cautious that it doesn't do what the HFO studies did, which was surprise us and say, hey, guess what? An open lung approach may not be the safest for randomly assigned patients.
There needs to be a trial that is a randomized control trial, but with people that know how to run the mode appropriately and run it the way they are suggesting it be ran appropriately. And then which strategy are you using for it? Because there is just TCAV, and then you have a different way to run it as well. So there's that as well. And I think that's the big thing is that people see it and they just want like a fix for settings, and it doesn't work. You have to.
And that's the thing. We haven't really established what's the best settings for which type of patients, and so anyone who's like, I heard it's good, like if someone's. Like I said, if someone's posting a case report on Twitter and someone gets excited and they want to go do it, this doesn't imply that you're going to have the same results as this person. And the problem is if you're not documenting these results in a very strategic way where you're capturing multiple data points, the question is it working? I'll give a totally different example. Inhaled nitric oxide, right? Years ago, we were using it off-label, right? That in adult patients, it's considered off-label. We're using it for ARDS essentially. And this is when it was very expensive. If you all recall, the gas itself, there was a patent on it. One company had the patent. It was very expensive. Prices have come down significantly. But so my manager at the time was like, we need to find ways of cutting our budget. And so she said, can you do an audit of our performance, like how we're managing our patients with inhaled nitric oxide? And basically we found that in 6 months, 7 patients were on it. The amount of time they were on it were significant. You can see that half of them didn't respond, but we were forced to keep it on by the orders that were written. And all of the patients but one died. So there was 0 clinical benefit, 0 titration when patients didn't respond. Like basically the protocol that we had written that allowed us to titrate was overrun every single time by a physician's order. So sometimes when you audit your performance, you realize that the things you thought were beneficial actually weren't, or they were completely useless, or in this case, it was a significant use of money. We don't bill we don't bill our patients in Canada. So that was coming out of the RT budget, this use of nitric oxide. So, it's important to understand that just because we feel something is doing well, we do need to study it in various ways to be confident that this is, and again, we may find that APRV in particular is really good for a certain type of patient group where optimizing PEEP is not. But until we have that data, we really don't know. And unfortunately, as much as it's been talked about and excited, like many people are excited about it, I was as well. Just so everybody knows, prior to me really critiquing research and understanding the evidence that we have on certain things, I was very pro this mode. And so my opinions have changed over the years to say, I think I need, and particularly once the Oscillate trial got published, where it was showing harm with HFO, and I worked in hospitals, used a lot of HFO. I was like, I don't want to be fooled again. I just want the evidence. I want the data, and I'm a one man show. I don't have the capacity to do a study by myself.
And I think that's what I was sharing with Madison, like, did they document or did they have document on certain things? Because we do. That's where I'm very fortunate to be networked with all of you. I actually used Troy's esophageal manometry documentation that he had shared with me a while back, and I implemented it into our documentation. And I also document Delta P with RTCAP patients as well. So that is where, like, if all of this, everything that you all are talking about, the EIT points, all the esophageal manometry, everybody, if they're going to utilize this and utilize it correctly, you need to capture all of it with your patients. Because eventually, especially where AI is headed, AI will be able to take everything that we utilize and put it in a big subgroup of research patients. And that is the thing as well. So I think we'll get more accurate data as long as all the data is built correctly, if that makes sense.
Yep, it does. We're over an hour. We're going to end this thing. Thanks to all the panelists. Thanks for all the participants. You can go to our website, www.inspire-rt.com, and you can find this recording there on YouTube shortly. Thanks again. Appreciate it. And somebody put a QR code up there. Was that you?
Yeah, that's to RT Inspire. If somebody wants to
sweet.
just quickly scan that, yeah, they can do that.
Sweet. Okay.
We can
Excellent.
I can also do this. There we go. Either way.
Okay. Either way, that's nice. Okay. Thank you.
Okay. Bye-bye.
Bye-bye.